Hello everyone, this is Rakesh Jain and I'm very much looking forward to giving you a quick primer on norepinephrine, the one neurotransmitter we under-discuss in mental health. And today we'll explore the unmet needs and clinical practice of norepinephrine in a variety of psychiatric disorders. So this is going to be a three-part presentation. I'll break it into 10-minute, hopefully more digestible chunks. Today we'll focus on part one. And our learning objectives, if I may put it that way, is to really put norepinephrine on the pedestal that it does deserve. There are lots of abnormalities with norepinephrine that show up in a variety of psychiatric disorders: major depression, PTSD, agitation, ADHD, cognition, lots of different disorders. So let's try and better understand it. So check this out. Norepinephrine really has its fingers in a lot of different pies. Look what I've created here. Norepinephrine certainly is involved in mood regulation, but also cognition, also inflammation. That's why the role of exercise and norepinephrine deserves to be further discussed. It actually also is involved in insulin regulation, sleep-wake cycle, aggression, irritability, withdrawal. All of that really listens to norepinephrine to a large degree. And it's not simply a matter of too much is good for us or too little is good for us. Optimum is good for us. Here in this illustration, I'm showing you too little norepinephrine often leads to fatigue, withdrawal states. Too much, in fact, can lead to uncontrolled stress. Our goal isn't to necessarily decrease norepinephrine. It's in fact to do the opposite of what the disorder is asking for. So the disorder may be driving an individual to too much norepinephrine or too little norepinephrine, or sometimes in the same brain, too much and too little in ways that harm a patient. Our goal is to find a way to normalize it. So this is a very useful illustration on the right-hand side. We're not interested in decreasing or increasing. We're interested in correcting. So if it's too little, we correct. If it's too much, we bring it down. And we don't want to just target norepinephrine. We should be reminded that monoamines are intimately tied to each other, and this dance between them is something that we clinicians should keep in mind. We'll talk more about that momentarily. But here I thought this quick, easy chart summation of norepinephrine overactivity and underactivity and the symptoms involved with it would be very helpful to you as we start diving into the literature on norepinephrine. First of all, if it's overactive, obviously the sympathetic activity is increased, arousal is hyperarousal. Sleep is actually fragmented. People can't sleep. They are sensitive. They're anxious. If you ask them how they feel, they say, I feel unstable. They're agitated, fear, irritability, aggression. And on the other hand, too little could lead to underarousal, not being motivated, too tired, unable to focus, unable to drive themselves into appropriate states of energy, and they report blunted affect and apathy. So to best understand this, we may have to think beyond DSM, and these RDoC criteria, research diagnostic criteria, have been very helpful. Let me tell you a little bit more about it, and if you are a norepinephrine appreciator, this model is really helpful. Let's check it out. So here we go. As we pull the curtains on the issue of RDoC, there are 5 different important elements. Negative valence, which is the presence of all these negative symptoms patients have. Positive valence, absence. People with these disorders don't feel motivated, don't feel oriented. They can't pay attention. That's the 3rd valence. Social, they're either too uninvolved or inappropriately involved. And of course, arousal and regulation. They can't control the levels of energy, which is really required for optimum functioning through the day. So the way to look at that is the following. Think of norepinephrine as being involved in all 5 of them. Negative valence, positive valence, cognition, social disruptions, arousal, and regulation. If you went highly respectful of norepinephrine, Until now, I'm hoping this new emerging science really gets you motivated to think along those lines. So the important key message is norepinephrine is a trans-diagnostic neurotransmitter. Try not to think of it as involved only in depression. It's involved certainly in anxiety, in depression. It's involved in agitation, irritability, post-traumatic stress disorder, and a number of different conditions. And as you see this thread being pulled, the more you examine norepinephrine, the more you appreciate how hard working this neurotransmitter is. So to clarify, what do we mean by trans-diagnostic? It means norepinephrine does not follow the sharp boundary rules set by DSM-5. It means it can appear in a lot of different disorders, and in fact, it can create a lot of seemingly paradoxical symptoms. In other words, there can be people who can have evidence of hyper and hypoactivity of norepinephrine going on at exactly the same time. Therefore, we clinicians have to be very wise about this and approach such patients with thought. The goal isn't to increase or decrease, but to correct where it's excess, where it's perhaps too rigid. So with that, thank you very much for this very brief introduction to norepinephrine. In parts 2 and 3, we will carry on and talk far more about the details of norepinephrine and pathology and how you and I can correct it. Thank you. Till next time.